On maintaining tissue integrity from a nursing perspective, we need to understand skin health, wound care, and nursing interventions. I am going to go into a little bit more depth on wound care and nursing interventions in another presentation, but let's get into this one. So we're going to explore the body's ability to regenerate and maintain skin and underlying tissue integrity. We're going to look at the nurse's role in identifying risk factors, assessing, monitoring, implementing interventions, and supporting the optimal skin functioning. So it's important that we understand the basic anatomy of the skin and what it does. It is the body's largest organ. It's going to provide a barrier against injury and infection, and it's essential in waste elimination, sensation, and vitamin D synthesis. There's different cells that have different roles in the epidermis. We've got the keratinocytes. Those are going to be the ones that protect from water loss, pathogens, injury. They are going to eventually shed right off. Melanocytes produce the melanin, which is the skin, the color for skin, hair, eye color, and they protect against harmful UV radiation. However, this does not mean that those with darker skin do not need sunscreen. Sunscreen is essential for everybody. UV radiation can get through the darkest of dark skin, just like it can get through light skin. It's just a little bit more difficult. Merkel cells are the ones that detect light touch, and you've got those in your palms and soles where you're doing a lot of that fine motor movement. And then Langerhans cells are the ones that are going to do the immune response in the upper layer of the skin. The dermis is that thicker layer with connective tissue, capillaries, blood vessels, lymph vessels. Um, it's got a lot of the strength and elasticity of the skin. And then you've got that subcutaneous tissue that is mostly just subcutaneous fat. And it also has blood vessels and nerves for thermoregulation and sensation. In infancy and early childhood, the immature skin can get macerated a lot easier, which is just that breakdown from too much moisture and irritation. So that's pretty much where diaper rash comes from. So we're going to do a lot of protection against diaper rash with our E&D, Boudreaux's butt paste, all the different kinds of creams that are out there. Adolescent and young adulthood, they generally are doing pretty well, but this is where our education becomes essential because they are going to think that it's cool to be tan, which if you have very light skin, yeah, you may think you look better with the tan. However, in your older age, it's going to result in a lot more skin breakdown and potential for skin cancers. So if we're avoiding that sun exposure and injury to the skin, while we're young, we're going to end up aging a lot better. Middle adulthood, we got that gradual decline in collagen and elasticity. Our skin hits its most elastic at about age 30, and then it's all downhill from there. And most of the aging factors that occur are actually related to gravity and sun exposure. So if we're able to avoid that sun exposure, we're going to age a lot less quickly. Older adults have that significant thinning, they have less collagen, they're at high risk for skin tears, pressure injuries, all sorts of chronic skin conditions. This is where your skin cancers that we're trying to avoid when we're younger are going to start coming out. Other risk factors, we've got that impaired mobility, spina bifida, cerebral palsy, anything that's going to make you a little bit more immobile is going to increase your risk of pressure. Chronic diseases, liver and kidney failure, cancers all make vulnerable skin. Obesity can decrease moisture. You're going to get maceration in those skin folds caused by yeast. You're going to have altered circulation. Malnutrition, making sure we're getting enough protein. Protein is essential for skin. Vitamins like vitamin A, vitamin E, minerals, they're going to all help with tissue repair and healing. And then sun exposure causes premature wrinkling and accelerated aging of the skin. If you look it up, there is a picture of a trucker that goes around where he drove his truck every day for decades, and the side of his face that was exposed to the sun through the window looks significantly older than the side of his face that was not. Types of wound care, we've got surgical debridement. They're going to go in an OR and get rid of that dead tissue and debris. Irrigation, we're using saline solution to clean those wounds out, get rid of anything on the surface, and decrease the bacterial levels. Best way to do this is to take a 10 to 20 milliliter syringe, pop a 22 gauge needle on it, fill it with saline, hold it a couple inches above the wound, and just put the pressure on it. It's going to work like a fire hose and it's going to get all that debris out of there. And then biological debridement. This is the one that grosses people out because we do have enzymatic agents like collagenase and papain, but we also can use black fly larvae to selectively get rid of that necrotic tissue. They secrete an enzyme that breaks down the necrotic tissue and then they're going to eat it. Wound dressings, we've got clean versus sterile. Sterile dressings are almost exclusively used post-surgery. It is impossible to have a sterile technique outside of the OR. Outside the OR, it's all going to be that clean technique for ongoing wound management. Dry versus wet. If the wound is wet, we're going to dry it. If the wound is dry, we're going to wet it. We want that nice moist wound bed. We do not want it too wet or too dry or it will not heal. And wounds that are covered will typically heal faster. Open dressings, like we use gauze, wet to dry is less commonly used because as it gets dry, it does pull out that necrotic tissue, but it's also going to pull out the good tissue. So we're going to do more of a wet to moist dressing. Semi-open dressings are multi-layered. We've got the therapeutic ointments, but we're not going to have a ton of drainage that we can take care of with those. And the semi-occlusive dressings, we can cover the wound and control the moisture and bacteria. Films are going to be like your Tegaderm. They are phenomenal for skin tears. Little old ladies and little old men want to keep an eye on those wounds. So if we're using a clear film that they can look at, we can leave it on for up to 7 days and they can just look at the wound. They're not pulling a dressing off constantly and re-exposing that wound to the elements. Hydrocolloids are more gel-like. They're an occlusive wound. They're not, bacteria cannot grow in them. That's why it says bacteriostatic. It just means the bacteria cannot continue to multiply. They're not going to kill them, but they're not going to allow them to grow either. They're really good for burns and pressure injuries where those nerve endings are exposed because it's going to keep it moist enough, but it's not going to keep it too moist. Alginates are great. They're derived from seaweed. They absorb a lot. So if we've got a wound that's very, very, very moist, we can shove that alginate in there. And those alginates also come with silver in them. Silver is a natural antibiotic, so we can put a silver impregnated alginate inside a very moist and exudative wound that's got a lot of pus and really dry it out and keep it from getting worse. Foams are great for mild to moderate exudate. They can be every 48 to 72 hours, and we can put them on a pressure injury. It'll help cushion it and it will help take care of the exudate. Hydrogels are great for dry wounds or something you're debriding, and they're really soothing for the skin because they are going to keep those nerve endings moist. Nerve endings hate being dry. Methods of wound closure, we've got our sutures and staples. They are going to keep the wounds closed, and those are going to be primary or delayed primary closures. Primary closures are going to be any surgical closure or any sutures or staples that are done in urgent care, primary care, whatever have you. Delayed primary closures are only done in ICUs. That's going to be a patient who needs a surgical washout of their abdomen, let's say, and the surgeon's going to go in, they're going to do the washout of the abdomen, and then to keep from the infection continuing, they're going to leave that abdomen wide open. They're going to be in the ICU because they need very, very close care. And then after the infection has cleared up and we've got enough antibiotics on board, they will go back to the OR and close them up. That is the only time you're going to do a delayed primary or tertiary closure, or third intention, excuse me. Skin adhesives, those are your little steri strips. Small minor wounds. They're protective, they're waterproof. The patient doesn't take them off until they fall off. Negative pressure wound therapy, these are your wound vacs. I call it arts and crafts for nurses because you have to cut that foam just to the right size. Those use a vacuum to heal the large wounds by reducing the swelling and increasing that granulation tissue that's bright red, beefy tissue. It's going to pull the tissue up into the foam and it's going to help it split more quickly, help those cells reproduce more quickly. It's very important to understand that the foam is not a sponge. It does not hold moisture. It will keep the moisture directly on the wound if it does not have that negative pressure. So with negative pressure therapy, after about 2 to 4 hours, if there is no pressure, they have to remove it and use a secondary, usually wet to moist dressing. Then we have our wound drains. They're going to decrease the fluid accumulation in the wound. They can be passive or active, and they can be open or closed. Common types of wound drains. We got our Penrose drain. That's just a flat tube that uses gravity, and we're just going to collect the drainage on a gauze. Usually we're going to put it in kind of a little or we're going to twist it around itself and just let it drain. The JP drain is that bulb suction device. We're going to put pressure on it, and it's going to suction the drainage out into the device. Large bottle drainage systems I haven't seen very often other than for like chest tubes, and we're going to change it when it's half full. And then the Hemovacs, they work very, very similar to the JP drains, and we're going to empty it when we need to. These get removed by nursing with a provider order. Primary healing or first intention is that clean laceration, surgical incisions, and we're going to close it with sutures. It's going to heal the fastest. Secondary healing is the wounds left wide open to heal. Granulation tissue forms from the bottom, and it's going to take a little bit longer to heal, but it's going to heal on its own. These are wounds that cannot be closed with sutures. They're going to be pressure ulcers. They're going to be your diabetic foot ulcers. The edges cannot be approximated or brought close together in order to suture them, so they're going to be left open. Delayed primary closure is that tertiary intention that I was talking about, where the wound's left open in order to reduce that infection risk before the surgeon goes back in and sutures it closed. Like I said, those are rarely used, and the only time you will ever see them used is going to be a patient who's going to be in the ICU because they are going to have one of their cavities wide open to avoid infection. Phases of wound healing, we've got that hemostatic inflammatory phase. This is that initial injury where the blood vessels are going to constrict. We're going to start getting the clotting, and then after the clot has formed, we're going to have vasodilation so the immune response can come out and get rid of the bacteria that may be in the wound. The proliferative phase is that granulation tissue is bright red, beefy, almost looks like ground beef in the bottom of the wound, and it strengthens with collagen. So it's really important. Collagen is a protein, and it's really important that we keep that protein level up. Then the skin's going to start to re-epithelialize, and keratinocytes are going to cover and fill the wound. In the remodeling phase, we're going to start replacing that collagen with stronger proteins. And we're going to get those wound edges contracted, and that can continue for over a year. This is when you start to get the scar formation. Sometimes the skin may go a little bit crazy, and you get what's known as a keloid scar, which is those scars that are way bigger than you would expect the scar to be. And those can be surgically removed after about a year, but it's important that we keep them. And any wound is very likely to open up again at that area. Unlike bone remodeling, skin remodeling tends to be weaker. Factors, diabetes. Diabetes is going to go after small blood vessels first. Smallest blood vessels are going to be the ones closest to your skin, all those little capillaries. So we're going to have that decreased perfusion, and it's going to impair the sensation. That's why it's so, so, so important that we have our diabetics keep an eye on their feet. We want to catch those wounds while they're small. Any infection. Wounds cannot heal if there is infection. So we have to treat infections. Foreign bodies. Wounds generally will not heal around a foreign body. They can, but it takes a lot longer. Medications like steroids, they're going to increase that blood sugar and prevent that collagen formation so that the wound can repair itself. Malnutrition, you need the protein, you need the calories, and you need all your vitamins in order to get the wound to heal. And then any necrosis or lack of oxygen to that wound is going to cause it to not heal quickly. Complications, infections, surgical site infections is anytime it's near a surgical site. Almost always is going to be a Staph aureus, which is just a normal bacteria on your skin that should not get inside of it. Um, Dehiscence is that partial or complete separation of the suture line when you've gotten a suture repair. Generally, you're going to have some of that reddish pink discharge first, and usually they're caused by something like a seroma, which is a accumulation of serum under the skin that causes it to open up. These we're trying to prevent by having patients splint their wound when they cough. We're limiting the amount that they can lift. We're doing all these things to try to prevent that wound from opening back up. Any wound that opens up and suddenly we've got intra-abdominal organs, we've got the liver coming out, we've got the colon coming out. Medical emergencies need a physician immediately. If you see that happen on the floor, we are going to put moist gauze over the extruding tissue. We are not going to ever push the tissue back into the abdominal cavity. We are always going to cover it with moist gauze and get the physician. It is a surgical emergency. It needs to be repaired surgically to avoid any potential infection. If we shove it back in there, we can shove an infection in and it's going to lead to a whole other can of worms. Bleeding, we can have internal, external bleeding. We can get a hematoma, which is just a big blood accumulation, not to be confused with a bruise. A hematoma tends to be larger and more solid. And then we can have a seroma, which is that serous fluid collection. A seroma or a hematoma under an incision can lead to dehiscence. So the nurse's role. We want to use the Braden scale. We want to find out who's going to be at high risk for these wounds. We want to make sure we're repositioning, use our supportive surfaces, protect those bony prominences. I know it gets repeated with pretty much every single thing, but it's so important to protect those bony prominences and keep those supportive surfaces in movement. We're going to do skin protection. If somebody's got a Penrose drain, which is that one that just comes straight out and we're going to coil it, we're going to put a piece of gauze under that coiling to prevent injury. Make sure we don't add extra pressure to the skin under it. Universal measures. We're going to use pH balanced cleansers. We're going to avoid vigorous rubbing. We're going to moisturize. Antibacterial soap has been marketed as one of the best things to ever happen to hygiene, but it is actually one of the worst. It is very drying, and if you're using it too often, it's going to get rid of the good bacteria on your skin. It's going to kill the white blood cell availability on your skin, and it's going to really damage that skin and dry it out. So we're going to use gentle pH balance cleansers. We're going to use a Dove and Ivory. There are special soaps like Lumi that are pH balanced. We're going to use all that kind of stuff to keep the moisture in the skin and keep the skin at the right pH. Making sure everybody's hydrating. Again, hydration is one of the best ways to prevent any complications. We're going to make sure patients are getting protein, omega-3 fatty acids, and vitamins. If we're not sure what the patient is getting, we want to get dietary involved. And we're going to promote that circulation with repositioning, mobilization. If a patient's had surgery, we're getting them up as soon as possible after the surgery. We want to prevent that hypoxia and ischemia from occurring before it does. Negative pressure. We're going to look at what the medical order says, and we're going to get the patient ready for the wound care. Always washing our hands before we do any kind of care. This is not a sterile procedure, so we're going to use regular gloves. We're going to take off the old dressing, look at the wound bed, note any exudate, and we're going to measure every time. We are not going to trust that the person before us measured. We are going to measure every single time we look at a wound. After we remove that old dressing and we look at the wound, we're going to wash our hands again and put on a fresh pair of gloves. Then we're going to irrigate the wound. We're going to dry it. I pat wounds dry. It is much less painful to pat a wound than it is to rub it. We're going to do barrier film around the outside to protect that healthy tissue. And we're going to cut the foam to fit inside the wound. Like I said, it is not a sponge, so it will hold any fluid where it is. Best practice is to do the barrier around the outside of the wound and make sure the foam fits the wound perfectly. If it's a little bit smaller, that is much better than if it's a little bit larger. And we're going to lightly pack it. We don't want to pack a wound too tight or else the tissue has nowhere to grow. And then we'll put the transparent adhesive dressing over the top and make sure it's airtight. When connecting the tubing, we're going to, in order to get that foam collapse, we're going to have to cut a very small, about dime-sized hole in that um, clear dressing we just did. And we're going to put the hole for the tubing directly over that hole. That is the only place there should be a hole in the dressing. And the foam collapsing indicates that the suction is there. You will get about 125 millimeters of mercury of suction for the general negative pressure wound. Wound cultures. Get our orders, get our supplies, educate the patient on what we're going to do, and make sure they're not having a ton of pain before we go digging in their wound. We're going to cleanse the area around the wound to remove anything from the surface. Staph aureus grows on the skin, so we want to make sure we cleanse around the wound to make sure there's no Staph aureus from the skin that we're going to get on that culture. Then we're going to use our sterile swab. I've never used a syringe. Usually, all you need is the sterile swab, and you're going to collect a sample from the wound bed, avoiding any of this healthy skin surrounding it. You want to get multiple areas of that wound bed. If you just get one spot, you may not catch the infection. So, best practice is to swipe it across the wound bed. We want to make sure our specimen is labeled and send it over to the lab. Dry dressing changes are pretty simple. It's just like doing a Band-Aid. You're going to take off the old dressing, look at the wound, document what you see, document how big it is, clean it, apply a new dressing, and then record everything. Assessing pressure injuries. Going to look at the medical record, see if there's anything that's pre-existing. We're going to look at the skin, especially over those bony prominences. Don't forget to look behind the ears if they're on oxygen, inside the nares. We're going to look for damage, redness, and blanching. If you push and it blanches, which just means it changes colors when you push on it, you have caught it in time to prevent the pressure injury. If you push on it and it stays the same color, you now have a stage 1 pressure injury. We're going to use the risk assessment tools. The most common one is the Braden scale. That's going to determine the patient's risk category. Patients at moderate or higher risk need to be repositioned every 1 to 2 hours in order to prevent injury. That is not to say that patients at mild or virtually no risk do not need to be repositioned, but they are less likely to have those injuries if they're not repositioned that frequently. We're going to adjust environmental factors. We're going to get new support surfaces if we need to. We're going to talk to the patient about how we need them to move. We're going to do everything we can to avoid that pressure so that we can avoid the injury before it happens. Then we're going to make sure the patient's comfortable, give them their privacy, and then we're going to document everything we saw. If we saw blanchable redness, we're going to put blanchable redness noted over sacrum, and we're going to document how big it was and what we did to make it better. Sterile wound irrigation, again, review the record, get everything together, make sure the patient's not in significant pain. We are always going to treat pain before we do any procedure. Half hour before is best practice. Take off the old dressing using clean gloves. Look at the wound. Write down any drainage. Write down how big the wound is. Then we're going to establish our sterile field. Put on the sterile gloves. Do the sterile basin to collect the irrigant. And we're going to irrigate the wound with a steady stream from clean to most contaminated. Never go backwards. Then we're going to dry the skin, apply the skin protectant, and put the dressing in the wound. Sterile dressings are rarely asked for, but it is still important that you know how to do a sterile dressing. And LPNs can do sterile dressings. closed wound drainage systems, turn off any external suction if we're using it, open the drainage, compress the reservoir, measure the drainage, clean the port, reseal everything. We're going to observe how much, what it looks like, does it have a smell, and we're going to keep an eye on that skin integrity around the drainage site. Documenting everything. If you did not document it, you did not do it. Just saying 3 years later when you get called to court, yeah, I totally did that, does not count. If you did not document it, it did not happen. It needs to be documented in the legal